everybody. Dr. Ryan here, board certified specialist physician, and I thank you so much for joining me in yet another hard hitting practical video in internal medicine. If you haven't yet subscribed to my channel, I strongly encourage you to do just that so I can look forward to enjoying your company on my channel. God bless you, and thanks for joining me, guys. Today, we're talking about a didactic approach um, to diarrhea. Did you know that diarrhea is hereditary? Yeah, you know why it's hereditary? Because it runs in your genes. Okay, guys, diarrhea refers to passage of loose stool, more frequent loose stool, at least 3 per day. And we classify it in terms of whether it's acute, being less than 2 weeks in duration, or chronic, being more than 4 weeks of duration. So, acute diarrhea, we have typical gastroenteritis and atypical, right? So, you got to ask the question, is it accompanied by severe illness? Then you consider things like ischemic colitis, surgical abscess. Does the patient look toxic and septic, tachycardic, pyrexia, and so forth? If it's bloody diarrhea, the other name for that is dysentery, you must consider an enteroinvasive pathogen like Shigella dysenteria, like Campylobacter jejuni, like Yersinia enterocolitica, and such things. If there's antibiotic use prior, always entertain the diagnosis of Clostridium difficile diarrhea. Antibiotic associated diarrhea, which classically forms a pseudomembrane over the colon, right? We diagnose that by looking for toxins A and B in the stool, and we treat, of course, with either flagyl or oral vancomycin, depending on severity. If your patient's immunocompromised, you must always consider the atypical infections, especially with your protozoal causes of diarrhea. We're talking about Microsporidium, Isosporibelli, cyst isospora, cryptosporidiosis, all the beautiful protozoans we treat with Bactrim, which is trimethoprim sulfamethoxazole. It could be a complication. It could be neutropenic enterocolitis. So watch out for that. Don't forget CMV colitis, especially in patients who are severely immunocompromised. So that takes care of the left-hand side of the algorithm. What about the right-hand side of the algorithm? More than 4 weeks, it becomes chronic. First question, is it spurious diarrhea? If no, is it bloody? And that's when we talk about inflammatory bowel disease, our good brothers, ulcerative colitis and Crohn's disease. And you guys remember the key differences between ulcerative colitis and Crohn's. Ulcerative colitis sticks to the colon. Crohn's can occur anywhere from mouth to anus, typically has skip lesions in between. In terms of the actual histologically speaking, the bowel wall, ulcerative colitis is limited to the mucosa and submucosa, but Crohn's is transmural. Ulcerative colitis has an association with the PSC, and Crohn's, like we said, also complicates with perianal or fistulas and abscesses and such things, right? If it's bloody chronic diarrhea more than 4 weeks, also think radiation colitis, think ischemic colitis. And if the answer is no, are there any other features of organic disease? Like then you consider lactose or food related, is a chronic infection related, TB of the bowel, chronic pancreatitis, malignancy associated, celiac disease, which is gluten sensitive enteropathy, where people have hypersensitivity to barley, rye, oats, and wheat. So it's a malabsorptive process. Prior surgery, small intestinal bowel obstruction, hyperthyroidism can drive it, as can carcinoid. You obviously want to probably get a patient a colonoscopy with biopsy. If the answer is no, then it's likely functional, and then you go into the irritable bowel syndrome territory. Consider age-appropriate cancer screening. Age-appropriate cancer screening. Having said that, and we've said this before, and we'll continue to say it, iron deficiency in a male is bowel cancer until proven otherwise. Consider celiac serology in the way of anti-gliadin, anti-endomysial, anti-transglutaminase antibodies. Clostridium difficile, this is taken from Medcomic, a lovely diagram or cartoon illustrating this. So I acknowledge Mr. Muniz and company. So these patients often have fever, crampy abdominal pain, diarrhea, but the key thing is that the patient was exposed to antibiotics before. So C. diff contains endospores that can survive the acidity of the stomach and reach the large intestine. The problem is that your normal gut flora is altered by these broad spectrum antibiotics, most notably clindamycin, cephalosporins, ampicillin, amoxicillin, fluoroquinolones. And C. diff then flourishes throughout the kidney. And the key thing is that if you do a scope, then macroscopically, you can see pseudomembranous colitis, yellowish plaques form of damaged endothelium. You look for toxins A and B in the stool. It's the most common infectious cause of nosocomial diarrhea, treat with flagyl and or oral vancomycin. My friends, in the book of Zephaniah 3:17, the paraphrase tells us that God is always silently planning for us in love. The Lord your God is with you, the mighty warrior who saves. Now he will take great delight in you. His love, he will no longer rebuke you, but he will rejoice over you with singing. Can you imagine that God sings? Yeah, God sings and he rejoices over you in singing if you love him, if you are his child. The Bible says in Romans 8:28, behold, all things work together for the good of those who love the Lord, those who have been called in accordance to his purpose. For those God foreknew, he predestined to be conformed to the likeness of his Son. And those of us who are waiting, looking forward to his return, the book of First John says we have this hope that we will see him. And when we see him, we will be like him. And if we have this hope, we will purify ourselves daily as he is pure. Have a great day, and I'll see you soon.